databases such as CINAHL and Medline and PsycInfo and Cochrane. And we searched a great amount of literature from about 2004 to 2013. So we started with 46,000 articles, and these articles were screened for the systematic review. But in the end, we had 287 primary studies and reviews that were included as evidence for this guideline. And you will be able to find additional information about our search strategy as well as all the citations on the RNAO website as supplementary documents. Now, levels of evidence. As you would have seen in the guideline, we use the following levels of evidence to substantiate the discussions of evidence for the recommendations. But it is important to note that the recommendations are not only based on the levels of evidence as you see on your screen, they are also based on the quality of the evidence, which is assessed by the research team using standardized tools such as ANSTAR or CAS, as well as the incorporation of the panel's clinical expertise and experiences. And finally, before we get into the details of each of the recommendations, I'd like you to know that there are 21 recommendations in total. 14 of them are practice recommendations, and these recommendations are for nurses who can implement these recommendations at the point of care per se. And they are divided into assessment, planning, implementation, and evaluation, which is the standard format for all RNAO guidelines. We also developed 2 education recommendations, and then finally 5 system organization policy recommendations. So Lorraine, the co-chair, one of our co-chairs of the guideline, will now speak to the practice recommendations.
Thank you, Grace. I'm Lorraine Telford, as Grace said, and I'd like to say that one of the things we started to worry about our work through when we first were working on a population health promotion model and looking at the nursing process was we didn't think we could get it to fit, but we did find a way to make that fit. So the population health promotion model can fit in the nursing process. That's great news. I'm going to highlight several of the 21 recommendations, and Carol Timmings, the other co-chair of the panel, expert panel, will continue until we cover them all. Our panel always had program and service staff and program leaders in mind when we developed each of these recommendations. And we intend that you are able to assess your programs and practices in relation to all of these recommendations and hopefully move towards best practices as needed. So we'll start with 1.1 and 1.2, and these recommend that it become a routine practice in all possible points of service or programs that young children are assessed such that behavioral risk factors for obesity are identified as early as possible in the lifespan. And 1.2 adds the requirement that wherever young children are, the conditions, for example, caregiver knowledge and skills, social culture conditions, economic conditions, also be routinely assessed for obesogenic risk. Assessing the broader environment wherever a child or a children's programs and services are delivered in the earliest stages in the lifespan is ideal. For example, barriers to participation can be identified in this kind of an assessment. 1.3 identifies the importance of assessing the school environment, again emphasizing the earliest period. Specifically, it emphasizes the focus on elementary school. We found that there was literature around adolescent well-being in schools, but in terms of the primary prevention of obesity, the research was much stronger in effectiveness for younger children. And in 1.4, we note that the research acknowledges the relevance of the physical and social community surrounding the school in the assessment of risk and protective conditions. So this could mean that a nurse, together with the staff running a community program or school event, working in a school, would assess a whole environment surrounding the children. So like a Y program for preschoolers would involve more than just planning the program for the kids, but assess the whole environment and integrate programming in that preschool program with obesity prevention actions and content tailored to that environment and assess its inclusivity, removing barriers, for example, for children with disabilities, children with low income, etc. We believe that there's sound evidence that a broader approach to assessment for obesity risk will contribute to more effective programs. So the next one is planning. The research related to planning in childhood obesity prevention showed effectiveness to be supported by participation of community stakeholders. Those here on the webinar who work in community health nursing or health promotion will appreciate these findings, as experiential knowledge is clearly supported by the empirical knowledge here. We all agree stakeholder engagement is critical. Stakeholders include school and daycare staff, administration and students, and children themselves, as well as the government officials, decision makers, and community members and leaders. All of these stakeholders' active involvement has been shown in the research to shift social norms in support of children's health and contribute to program success, from service-level interventions to policy change initiatives. If you need more information about stakeholders, in the Implementation Toolkit, there is a chapter 2B that is all about engaging stakeholders. Next one is the practice recommendations around implementation. We have 5 or 6 of these, remember right now, and each one deserves a full attention, full plan of action. So they seem small, but each of these is a huge initiative. For the first one, the promotion of breastfeeding for the primary prevention of childhood obesity. The next one is around supporting parents. The next one, is around supporting parents with knowledge, skills, and ensuring caregivers of young children in all settings are aware and supported to provide all preschool children with healthy eating and physical activity. And that's actually for 3.2 and 3.3 together. And then the next slide talks about the other 2. In elementary schools, the research supports collaborating to promote regular physical activity and ensuring health and nutrition education is integrated. And for the 3.5, this is around focusing on improving the school food environment. There is much more evidence about that now than there was in the 2006 version. So for example, there's strong evidence, just looking at the whole implementation recommendations right now. An example is that there's some strong evidence for reducing screen time initiatives, for increasing physical activity and healthy eating in preschool children when they're in structured preschool settings, and that this is effective in promoting healthy weight management and preventing childhood obesity. In addition, it's essential that for school initiatives, the obesity prevention programs be embedded in broader school programs, health programs that support mental health and overall child growth and development. That is, that these programs are not narrow, they're comprehensive, and not to just be limited initiatives. I mean, you have to start somewhere, but the aim is to get to that comprehensive, broad initiative embedded in the school culture. So comprehensive school health programs show the most success for child health outcomes overall, including obesity prevention. Also, again, focusing on younger school children should be the priority. So it'll change to Carol in a minute. I just want to say that I bet you're thinking, just how are we going to fund all these initiatives? And I just want to remind everyone, there was a time when we didn't have resources for many services that we do in public health and health promotion, and they were built over time. For example, even now, we're still seeing changes to the immunization programs, and they're getting more enhancement. Those didn't exist at one point. Or for some provinces, there's been money allocated to more and more early years programming as the research around brain development has come to light, which also has lifelong consequences. So it's our expectation that this evidence-based guideline supports you in making the case for better resourcing for these effective strategies. So just as the resources for comprehensive, effective primary prevention planning and delivery are needed, resources are also needed for solid evaluation and population health promotion of primary prevention of childhood obesity. So Carol will take us into evaluation and more.
Okay, thank you so much, Lorraine, and to all of you for joining in on this webinar. So as we go about implementing this sort of myriad of best practice guidelines and the recommendations, we do want to emphasize the importance of evaluating the implementation and ultimately the impact that these guidelines have had. And in addition to that, we know that evaluation results always give us insight into opportunities for improvement and refinement, and even looking at areas where there may be deficiencies in some of the initiatives. And this can be either process or outcome evaluation. And the guidelines speak to the fact that this can actually be undertaken in the home environment, which we know is an incredibly important environment in those early years, by using age-appropriate tools through supportive parenting programs, and also really doing, as Lorraine talked about, a holistic and comprehensive approach is really an underpinning of all of these recommendations. So we need to look at the socioeconomic factors that may be putting children at risk in their homes and challenging parents and caregivers, and really look at what we can do to mitigate that. We also know the other recommendations speak to measuring and evaluating the impact of healthy public policy. And we recognize, and the panel certainly recognizes, that this is challenging, but it's also really important. And we know that it is often through policy change that we shape health supporting environments. And these are the environments within which children and their parents and adult influences are living their lives, and that we want behavior change to take place. So, whether we're looking at policies in relation to healthy eating in schools or physical activity, it's really important that we keep our eye on these policies, we advocate for them to be in place, and take an active role in evaluating those. So the next slide speaks to education recommendations. And, when we look at the tremendous capacity and talent that we have across the system in our workforce, we also have to kind of look ahead at the skill sets and knowledge base entering the workforce. And so to that end, the panel and certainly the literature support the importance of ensuring that principles of primary prevention, social determinants of health, in addition to subject matter expertise or content expertise in areas of healthy eating, physical activity, healthy growth and development, and mental health and well-being, are really a much more emphasized part of the curriculum in undergraduate education for nursing and for other healthcare providers. And so that is really highlighted in this recommendation. And because we then know that people will enter their practice, whether that's in public health or other areas of primary care, education, and so on, with a sound knowledge base and the skill to actually undertake the planning and implementation and evaluation of this work. So that is an area we wanted to draw attention to. And the second recommendation on this slide, I think, recognizes that we are all knowledge workers. And as such, we have a responsibility to ensure that even when we've been in the workforce for many years like I have, that our knowledge stays current, that we're always building our knowledge and skills and integrating that into our practice to make sure that we're refining, integrating the new knowledge, refining the initiatives that we're evaluating, and really taking those findings and tailoring our approaches and interventions to take that into account. So really those recommendations speak to undergraduate education and, of course, our need to go on and ensure that we integrate that into our work as professionals. Now, the next set of recommendations take us to that sort of system, broader system level and organizational system level in relation to policy recommendations. And I would draw your attention to the fact that both of these recommendations are new, because as we looked at the literature, there is growing and growing evidence that the impact that healthy public policy can have in shaping those environments in a sustained way. And also, really, our efforts that are geared to behavior change will be much more successful. We're really, establishing environments where people actually, have a much better chance at optimal health. So when we look at whether or not we're advocating for healthy public policy, we may be leading that policy change or working with a team of people in terms of that policy change. We want that policy to be comprehensive, and you'll notice language in the guideline about enforceable. And some of you may be sitting there saying, how do you enforce policy? Well, what we mean by that is we want the policy to actually have strong language around requirements, mandates, that really put teeth in the policy. And then we will work along with our other cross-sectoral partners to support the uptake of that policy and to really, ensure its success and then evaluate the impact that that's having. And the second recommendation here looks at the fact that as we collaborate with other organizations and across sectors, we really are looking at policies in not only education and childcare environments, but broader healthy public policy that might look at things like marketing to children or the built environment where, we're looking at cycling, built environments that are more conducive to people being physically active, safe parks and, active transportation, safe cycling. So we have a role to play, and these best practice guidelines really emphasize that as a critically important area where we really need to use our influence and our knowledge and skills. The next two also speak to organizational and system policy, but 6.3 is specific to the food environment, where we really critically examine the opportunities. Certainly the research is showing that within the school environment, that is a critical food environment for children. And so to that end, we have seen, and I've certainly seen in my work in Toronto, just the tremendous impact we can have, whether that's through curriculum and supporting curriculum implementation, or really supporting that kind of healthy eating practices in school cafeterias or school lunch programs, breakfast programs, and so on. And then, of course, things like vending machine policy and recreation centers. There's just such a myriad of opportunity, and the guidelines speak to that. And then in 6.4, we must also ensure that any policy initiative that we are championing, whether that's in a school environment or a broader municipal policy or at a provincial level, we want to make sure that that policy is assessed for its impact on health equity. You'll see in this entire best practice guideline document the acknowledgement of health inequalities and of the need to ensure that our work is supporting health equity and not, in fact, increasing any disparities. So we want to pay attention to that. So this holds true for our healthy public policy work as well. And there are a number of tools available that many of you may already be using that are health equity impact assessment tools that can really help us ensure that the policy is good for all children, especially children most at risk and most disadvantaged. We want to make sure that our policies are inclusive. And then the final recommendations in relation to this look at something that I'm sure when you read this, you may have taken a deep breath, because this is ambitious, but I think we're up for the challenge. And that is really advocating for the establishment of a comprehensive population-level surveillance system to monitor not only the risk and protective conditions, but also the kind of progress that we're making. We've seen this for communicable disease control, and I have to say personally, it's part of my dream that we might see this for chronic disease as well. And I say there's no better starting place than in the primary prevention of childhood obesity. And as a panel, we grappled with this. I'll be honest, Lorraine referenced most appropriately that we had some really rich discussions about what this might look like, and not only the complexities, but where's the starting point. So we spoke about the importance of anthrometric measures at a minimum, height and weight, and of course other measurements and indicators that can measure levels of physical activity, intake of fruit and vegetables, many healthy eating behaviors, that we actually can come up with meaningful indicators and really look at measuring those systematically across the province or across the country. So we're recommending a comprehensive assessment and monitoring system over time. And I have to say to my colleagues on the line that I believe we can build this from the ground up. While we're advocating for a national surveillance system or provincial, wherever we see the opportunity to direct our advocacy efforts, let's not wait. Let's begin to build this at the local or regional level by beginning to collect data. You know, we're doing that in the jurisdiction I work in, where we've actually undertaken a student survey to do some direct measures of height and weight and to really begin to measure in a systematic way what's it looking like in our school community, and then begin to monitor that and measure the impact of our programs and services over time. So I think that's something that's ambitious, but we need to kind of reach to that level, because this is a very daunting and complex issue. But I think we're up to the challenge, and this guideline is very forward-thinking in that way. So, Imogene, I'll now turn it over to you to talk about guideline implementation. Thank you.
If Carol says it, we can do it. We can do it.
Thank you very much, both of you, Lorraine and Carol, for that very obviously knowledgeable overview of the recommendations. Now, I do want to just draw your attention to, before I move on, 2 questions, and just to whet your appetite for questions. We have one question that is, what are key messages related to parents that our 2 co-leads will answer? And another key question, what is the role of sleep in the prevention of obesity? Now, before I turn over to the questions, though, and I want to talk a little bit about implementation, but even before that, I wanted to ask Grace if she would make a comment on the statements you see behind each recommendation. It says new for some and updated for others. And I wonder, Grace, if you might just let us all know what does that mean?
No problem, Member Jean. The latest edition of the guideline is a comparison, is an update to the 2005 version of the guideline. So where you see update, that's where the recommendation was essentially the same from the 2005 version, although the discussion of evidence was updated with regard to our latest literature. Where the recommendation says new, that's where it was a new recommendation that was not found in the 2005 edition, and therefore it's a new recommendation as well as its related discussion of evidence.
Oh, thank you very much, Grace. And I think that's really critical that you know in many of our guidelines, 2nd and 3rd editions, what we find is the direction of the recommendation remains the same, but in fact we have more and stronger evidence in relation to that recommendation. Now, I'm just going to move on to speak very briefly about guideline implementation. We have these beautiful recommendations, and we know from our almost 15 years at this work that guideline implementation is challenging, it's multifaceted. There's no one best approach. In fact, we've learned that multiple approaches work best. And we also have learned that uptake of knowledge in any practice setting requires much more than awareness raising and distribution of guidelines. And I'm afraid that many think that it's just enough to say this guideline has to be implemented. There are very specific strategies that come from a growing body of knowledge that we now term implementation science. And RNAO and all its work with its partners, many of whom are spotlight organizations, are living and learning and contributing to this knowledge every day. One tool that I would direct you to is RNAO's Toolkit, Implementation of Best Practice Guidelines. The 2nd edition came out at the end of 2012, and it does outline what that evidence-informed systematic process to guideline implementation consists of. And we will be addressing many of the elements in that toolkit with specific reference to the obesity guideline in our subsequent sessions with this webinar series. I do want to also draw your attention to where you can find more information on guideline implementation strategies, and that will be in our next webinar, which will be July 31st from 12 to 1 Eastern Standard Time. Of course, it's different in your jurisdictions, and we will definitely communicate to all of you again with a reminder. You can download RNAO's implementation toolkit from the site mentioned below. And in addition, you can download all of our best practice guidelines, including the primary prevention of childhood obesity guideline from the RNAO website. Now, and here is the slide that tells you exactly where to download the primary prevention guideline. I do want to reinforce the title. It is primary prevention, and the guideline expert panel paid special attention to that focus, and you will note then that the recommendations do address primary prevention. And you're, of course, if you wish a hard copy of this guideline, you can contact RNAO. So now we are going to move into our questions, and we're delighted that we are getting more questions. And the first question is, what are the key messages related to parents that come through in this guideline? And I will ask our two experts.
Can you hear us now? We moved the microphone, and I think my small technical finger difficulty happened. Thank you. So the first question is about messaging related to parents. And what I was saying is that the nurse and the parent are in a therapeutic professional relationship. And so it's in health promotion approaches, it's always an empowerment model. And it's very important not to blame parents or blame the family for what's going on. I'm assuming you're speaking about all parents, but a lot of times people ask this question when they're thinking about parents where there are indications of poor behaviors. And so you develop a therapeutic relationship with the client, and there is actually a therapeutic relationship best practice guidelines, so I'll remind you of that. And you work with the family, and you do that, you implement a process with the family like you would with any other health concern. Some of the important messages that we think you can focus on are screen time, which is television, AV aids and entertainment units, and physical activity. And there are new physical activity guidelines that are created by the federal government and available, and they're in the toolkit at the back of the guidelines. But another key message I find important with parents is that physical activity and sedentary behaviors are two different things. Being physically active doesn't cancel out being sedentary. So we need to think about talking to parents about that. Even if their child is in hockey, if they spend half their time texting or on Facebook or watching video games, playing video games the rest of the time, it's still too much sedentary activity. So that is something to work with parents on, and understanding the difference between physical activity promotion, doing physical things, and sedentariness. All right. The next question was about the role of sleep. Should I go ahead and answer that one too?
Yeah, you could as well. On any messaging
what is the role of sleep?
Relationship between sleep.
Yeah. So what we did is, in the literature we did identify some studies that explored the relationship between sleep and childhood obesity, and there is some promising results in that research, but it's too soon to form a recommendation. And in the guideline on page 64, you will see there's actually 63 and 64, there's 2 pages of research gaps that we identified, and this was one of them. So it's a promising area, and I encourage you to keep up with the literature on that one if you see that, but there does seem to be some connection, so we'll monitor that.
Okay, we have another question here. Our third question, what about educating prenatal families for gestational weight gain and linked to childhood obesity?
You can speak to that, Grace?
Yeah. From a research stance, with regard to our systematic review, we couldn't find sufficient evidence on the prenatal preconception interventions in our systematic review to warrant a primary prevention intervention focused on maternal behaviors during pregnancy and weight. For example, in Health Nexus in 2013, they had said that it remains unclear if maternal physical activity and nutrition counseling interventions reduce the incidence of childhood obesity. It's not to say that we don't recognize that sleep, along, for example, mental health and prenatal care aren't important contributors to child health. So we fully support that. We just need to be able to, we just highlighted these topics as areas for future research and guideline consideration with respect to their specific association to the primary prevention of childhood obesity. So we're hoping when the next iteration comes around that we will be including these recommendations as well.
Okay, thank you, Grace. And we have another question that I think Grace will address, and it's, is there a component in your guideline to promote nutrition and cooking skills to high school students who will eventually be parents?
That's actually a really great question, and as a panel, we grappled with this as well. Because our focus was on primary prevention, we really wanted to focus on the earlier years. So although it's very important to also teach nutrition and cooking skills to high school students, we chose to focus on the earlier years to be able to create the most impact with regard to primary prevention. We saw adolescent health as sustaining those, those healthy habits. And we actually have an adolescent health best practice guideline that we also reference as our guideline as important to be able to nurture those skills.
Oh, thank you very much, Grace. Now, I'll turn over to, we're just getting questions fast and furious. We're so excited. So we want also to have the question, do you have any plans on how to measure advocacy efforts?
Well, that is always a challenge, isn't it? I mean, we often think that our advocacy efforts are only successful if we get the actual outcome we've been looking for by way of a program or a policy change or whatever. So we don't have a plan per se, although I think certainly if you look at, we certainly can come up with intermediate measures around, you know, as a result of our advocacy efforts, are people more aware of the health issues? So I think we can measure people's awareness. We can measure people's intention to undertake some sort of change as a result of our, you know, depends on the kinds of advocacy you've undertaken. We often look at media advocacy, I think increasingly social media advocacy. I think we are quite adept at cross-sectoral advocacy, finding those people who bring different perspectives to the credibility of advocacy. So I think measuring advocacy efforts is a challenge, but I think we can work to define intermediate measures to begin to look at, for starters, are people aware of the very issue we're trying to bring attention to? For example, I don't know. I mean, the evidence is not showing that there's a tremendous level of awareness of what the longer-term health implications will be if we don't address the growing problem of childhood obesity, right? So, you know, it's incumbent upon us to bring awareness to that, not in a fear-mongering way, but in a we can change this trajectory. Yeah, I can do the second one as well, Irma Jean. And this question says, does RNAO support measuring height and weight in schools? Well, certainly the recommendation around anthropometric measures is in the guideline because we do believe that self-reporting, and certainly the evidence shows that that is not an accurate way to gather this data. And so we do encourage direct measure of height and weight, and certainly in the school environment is a good environment to do that in. However, we do acknowledge that in undertaking that kind of direct measurement, there's lots that you must consider in terms of ethical considerations in your practice. It must be done sensitively. You must do it with great transparency, consent, a lot of education up front so people understand why you're doing this measurement, what you're going to do with the data. So pay a lot of attention to planning, kind of this sort of data collection undertaking in the school environment, setting the context. It's often best done, as the research would show, in conjunction with gathering information on other health behaviors. And of course, staff who undertake this need to be knowledgeable, well-trained. The accuracy of the measurement must be ensured. And of course, like anything, we always have to be prepared to deal with what may come up in the process of doing these direct measures. So we certainly, in the work we undertook in Toronto, made sure that we had lots of ancillary processes in place where nurses would be available to speak with children, after the measurement. If the children asked what their height and weight was, we disclosed that in a very confidential way with the child. It was done with consent. So all kinds of considerations. The bottom line, the school environment is the perfect environment to undertake this if it's done well.
Okay, thank you very much, Carol. Now I'm going to turn things over to Grace. We have a question here. Does the new edition of the guideline have developed evaluation indicators or new indicators? And this comes all the way from Spain.
That's actually a really great question. On page 66 to 69, or more so 71 of the guideline, we do have evaluation and monitoring, detailed indicators for the recommendations of the guideline. But I'm thinking you're talking about Enquire, and they are in process. So they are being worked on, but we do not have the full set of indicators as of yet, but it should be coming soon.
Very good. And for those of you not fully aware of Enquire, that is our database system related to each of the guidelines, where we have developed outcome indicators for each guideline, as well as structure indicators and process indicators. So we have a few more questions that I'll read, and we'll turn over to Lorraine. Next is, what is the messaging related to healthy eating for parents? And then she'll move on to another question. Was there any evidence about how to implement these guidelines without adding to weight stigma, particularly when it comes to surveillance? And that's really a bit of a carry-on of what Carol was talking about. So take it away.
Sure, thank you. I need that one because I have my notes. And Carol, I think, will speak to the second question once again. She spoke to it a bit too. But the healthy eating messages for parents, I think it's disappointing to see little research in the literature around health communication and messaging. Health communication is a particular, expertise area, and people have PhDs in it. Yet it hasn't really made its way to research in this area. There's more messaging around smoking and, other risk management, diabetes education, and things like that. But very little has been done, and I think that it's because, again, we're working with children. It's more complex to do the research. So I do think we have to ask for that more. I think the other problem is this gap in knowing what the key messaging should be in terms of research is that once kids hit school, even though the parents are still quite critical to their nutrition world, the school environment sort of takes the attention of the researchers, and parents were kind of left. Now, you'll see more in the recent literature, better studies show every initiative engages parents and has messaging related to parents. And we went through that with the smoking thing too, where at first we were just targeting the kids, and then we realized we had to send things home to engage the parents. So I think that comprehensive school approach is the answer to messaging for parents, and that is to engage more parents. And when you start to see the policy changes within the schools where they don't have sugary sweets at every bake sale, et cetera, that whole policy shift, you are reaching parents in an indirect way. But research is lacking there. The next one about adding to the weight stigma, is there any evidence about how to do this without adding to weight stigma? There is no evidence, but our panel really struggled with making the recommendation given that we're not sure. But as Carol said, the health consequences are so significant and it's such a serious issue that we have to do what we can do and do it well. So I don't know if you want to add to that.
I'll just add one thing, Lorraine, and these are all incredibly important questions, and the panel did have a lot of lively discussion about this because we certainly would never want to undertake something that adds to weight stigma. We acknowledge that that is already taking a toll, in society. So, having said that, there was also consensus among the expert panel that for the last decade or more, our approach to not measuring has not served us well. We have skirted around, we better not measure because it could stigmatize, it could, as we watch obesity rates continue to rise. So we actually did arrive at a very solid consensus that we do need to begin to establish baseline data. We do need to undertake measurement and do it in a very sensitive, ethical way. But if we're going to ever measure impact, and if we're going to turn this impending health crisis around, I don't think we can do it through just self-reported data all across the board. So, but certainly we must ensure that any work we undertake, whether it's in this best practice guideline or others, that it doesn't stigmatize, marginalize, but rather we have a solid rationale of how it links to the work we're doing and that we're evaluating the impact of that work. So thank you for that very important question.
We also imagined a future where that kind of measurement can be done unobtrusively and safely. So, get those technical people out there to create some methodology to do it in a way that's not stupid.
There we go. Okay. Can you hear? Our question period has come to an end, and I'm thanking you all for this spirited question period. And we will share information on the remaining questions. I'm not sure how. Unless you want to do it right this minute and see if we can do it quickly. Any thoughts on training healthcare providers in screening prenatal clients using BMI?
The last question. So really we're talking about training healthcare providers, period, on BMI, whether it's prenatal or not. We do think that healthcare providers don't have great skills, but again, the literature was silent on this. But we don't think that many healthcare providers understand how to interpret percentiles and how to communicate them to parents. This is what the expert panel talked about. BMI is another layer of complexity as well. So we would recommend further that you go ahead and implement a project like that because there is a need, and do an evaluation and publish it. That's our real message here, is that it is an issue. We all recognize it. There's no literature on that.
Okay, and one final question, Carol, I'm going to direct to you. How can we help increase activity in schools as a school nurse?
Well, I think there are many activities and initiatives that we can undertake. I think, first of all, we know, and as myself having worked in a school as a public health nurse, albeit many years ago,
You know, initially you need to go in and establish those relationships with the teachers and school staff around, you know, understanding their environment and their pressures. Because I think the thing we'll often hear is that there is no time. I don't have any time. And it seems to be the dispensable part of curriculum that goes. And so I think really working with teachers and influencers in that school to kind of talk about how can you practically integrate physical activity into the day, into your classroom. And I know the public health nurses have an amazing knowledge base around how to integrate physical activity into the student's day, whether it's, you know, playground games, looking at stretch breaks in classrooms, really kind of working with the teachers to embed that in the curriculum. I know in some of the senior schools, senior middle schools, you know, tapping into children who want to be peer leaders and that sort of thing. So I think there's many, many ways that we can do this. I think, first of all, though, it's getting a credibility in that school by building relationships with the opinion leaders and the gatekeepers in that school. And then once you've got your toe in the door, away you go.
Well, thank you so much, Carol and Lorraine. This has been very active and very informative. I did want to draw your attention again to how to access the guideline, and the slides from this presentation will be on that same guideline page later today when you look to access it. So give us a little bit of time to load it, and then you'll find it there. So I did want to say that if you need more information, want more, which I'm sure you do, about this guideline, contact Laura Sykes, the RNAO project coordinator. Her email is there. And we ask you also to fill out the evaluation at the end of this presentation and click on the URL link, and it'll take you right to the evaluation. I want to thank you very much for joining us today. I particularly want to thank Carol and Lorraine for sharing their intelligence in relation to primary prevention of childhood obesity, as well as Grace for sharing all of her knowledge about the background, the evidence related to this guideline, and Lorraine Sykes for helping us deliver this presentation to you. Stay tuned then for our next presentation, which, as I said, will be July 31st, 12 to 1 Eastern Standard Time, and focusing ahead on implementation of primary prevention of childhood obesity. Thank you all, and have a continued good day.